Welcome everybody. Can you hear me? Because it's kind of an echo from here. So welcome to this Independent Satellite Symposium, the Commanding Heights of MDS Care. It's actually very nice to be here at Soho and see how this meeting is really growing. It's actually my pleasure, honor actually, to be co-hosting you with Dr. Amy DeZern, who is a professor at Johns Hopkins and the lead of the MDS and bone marrow failure program there. So it's been a great colleague for many, many years now. So also we want to thank the Medical Learning Institute and PeerView for providing this session, and the sponsors that are Bristol Myers Squibb, Geron, and Novartis for providing educational grants that allow for this symposium to happen. I think you heard already that you need to please complete the pre-event survey. And then as a reminder, please look out for additional follow-up polling during the presentation. And then please submit your questions and we will try to answer them during the Q&A answer. So this is to remind you that if you go to this website, you can actually view the slides and the practice aids, and you can actually download them. And with that, before we start the session, we have some polling questions. So I think the instructions are you have to focus on this QR and then go through what the website will prompt you into. So the first polling question will be, in your opinion, what are some of the major challenges and persistent treatment gaps that we face in managing patients with low-risk MDS or high-risk MDS? So lack of effective options in high-risk disease, under-treatment of disease symptoms, impact of red blood cell transfusion dependency on survival, or outdated prognostic models and tools. So if you can please vote. Thank you. Okay, so it seems that it's still moving. But it seems that, and I agree with what I said, that basically we all agree that we need more effective therapies in high-risk disease. We would like to be more effective in treating the symptoms of these disorders and also the impact of transfusion dependency. And maybe clarify some of the confusion regarding prognostic models and tools in this disease. Okay, now, obviously it's not that we're doing ultra tremendous progress every few months in this disease. Indeed, actually, we've been working for now almost 2 decades with, you could argue, a relatively slow progress. But I think over the last couple of years, actually, we've seen an increase in the pace of innovation and actually the approval of new compounds for our disease. And on top of that, we've seen quite a bit of progress also in the understanding of this disease. This has translated into new classifications and prognostic tools. So on your right, you will see some of the drugs that were approved for myelodysplastic syndrome the last couple of years. So they include luspatercept that now has 2 indications. We also saw the approval of decitabine cedazuridine. This is a true oral hypomethylating agent also a couple of years ago. And then, of course, as we discuss in the next couple of minutes, new prognostic classifications incorporating molecular data, such as the IPSSM, that I think is a major improvement in our way to evaluate our patients. And then this last column with all these question marks, unfortunately, may be dropping a little bit in terms of what we would like to see in terms of approvals and doublets and potentially triplets, but still with quite a bit of interesting compounds, particularly, for instance, BCL2 inhibitors, TIM3 inhibitors, IDH inhibitors that are already approved in AML, but we believe have an important role in myelodysplastic syndrome. We would like to see some form of immune therapy approved in this disease, so CD47, and of course we have a major problem that is that of TP53 mutated disease that really affects a significant fraction of our patients. And we also heard some positive data that is quite relevant with telomerase inhibitors also in patients with lower risk myelodysplastic syndrome. So we will hope actually that 2024 could be also a very successful year in terms of new drugs for our patients. Now, despite all this, it is obvious that we are not curing a significant fraction of our patients and that we need to do much better. Actually, there is data from different sources, for instance, from this Connect Myeloid Disease Registry, that is a very important tool, where we see that basically a majority of our patients with MDS actually only receive supportive care. That is actually quite unusual, and that there is actually a large cohort of MDS patients, and this is SEER data, that when you look at their outcomes with conventional therapies, actually is quite poor, with survivals that actually less than 1 year. We also are facing this problem of what is the real need for patients with low-risk disease, for instance, that is that of transfusion dependency. And you see here that we're still lagging in terms of helping our patients improve in terms of, excuse me, I apologize, in terms of this particular issue that our patients. So what are the goals for the session today? So I hope that at the end, we will have enhanced your understanding of factors that can inform diagnosis and prognosis in MDS. Hopefully, we will increase your knowledge in terms of evidence supporting innovative therapy for patients with lower and higher risk myelodysplastic syndrome, give you some skills that you may need to develop a personalized MDS therapeutic plan, and then maybe provide you also with guidance in terms of practical aspects, in terms of modern therapeutic approaches for our patients, including dosing and safety management. So let's start with some of the new developments in terms of baseline assessments and prognostications in this disease. So there's some diagnostic criteria and differential diagnosis. Actually, this is kind of weird what I'm going to say, so maybe I should not say that. But this is one of the interesting aspects when you see a new patient in the clinic, that is actually, does this patient really have myelodysplastic syndrome? Do you exclude some other condition that may be what really is happening to the patient or maybe contributing to the disease itself? So you basically see in the slide the diagnostic criteria and the differential diagnosis. So you need some level of cytopenia. Of course, that's not definitive at all. There is some what they call decisive criteria in terms of dysplastic features, maybe the percentage of blast, some karyotypic or evidence of clonality that basically means some type of mutational event that is very common in patients with myelodysplastic syndrome. Below, you see basically things that are quite standard in terms of exclusion criteria, but the reality is that sometimes these things can actually coexist with a proper diagnosis of myelodysplastic syndrome. And then at the end, you see things like congenital syndromes. Indeed, Dr. DeZern is an expert on this kind of hereditary conditions that may be in the context of bone marrow failure or may not really be in that particular context, that we see as we are deploying more of these molecular tools more frequently in our clinics. Now, as you know, there's been quite a bit of controversy perhaps in terms of new classifications for this disease. I'm going to be upfront. I'm a WHO person. I don't really agree with a lot of the criteria from the ICC, but maybe I'm wrong, and maybe you don't care about that, but I'll come out about this. But I think actually both classifications have merit. I think it's really important actually to really start implementing some of the molecular knowledge in terms of understanding what is the natural history of this disorder. So this is a summary of the 5th edition of the WHO MDS classification. Indeed, today, actually, at in the meeting itself that Dr. DeZern and myself will be chairing in a couple of hours, Dr. Curry is going to be giving us a presentation in terms of this topic, so I'll skip over here. If I want to make a point in terms of WHO, I don't like the name. I don't like that we call these myelodysplastic neoplasms. Why? Because I think these are syndromes. Yeah, these are leukemias and cancers of the bone marrow, but we know that they affect systemically many other tissues like the heart or the lungs, and therefore I think these are actually syndromes. And I will hope that in the future, whoever makes these decisions thinks about changing the name back to a more broad term. But again, it doesn't really matter what I think. For many years, we wanted to have a more robust prognostic tool. And actually, this is very interesting because in the future, I don't know if we're going to live in two worlds or not. You'll understand what I'm going to say in 1 second. So we knew for like 10, 15 years the importance of molecular data, how frequent molecular alterations are in patients with myelodysplastic syndrome. We use this already actually somehow to decide therapy, but we wanted to have a comprehensive prognostic classification that could incorporate this molecular data. So this is actually now happening thanks to this IPSSM classification. I'm pretty sure that if you're here, everybody has used it or play with it or maybe heard about it. But this is really important tool. It's kind of very easy, democratic to use. It's free in the internet. And it's actually very powerful tool that I use actually in my clinic together with IPSSR classification that this tool will give you automatically to basically have an idea before therapy in terms of what is the expectation for my patient with either low-risk disease or high-risk disease. So you can go to the link there. This is actually straightforward. Of course, you need to have kind of the IPSSR data. So you need to have cytogenetic, you need to have a genomic panel, and then it's very straightforward to actually input this. And this will give you this kind of what I call symmetric classification as opposed to the IPSSR, because now we have like 6 subgroups that go from the very low to the very high risk, and it gives you a validated idea of what the survival of your patient is going to be without therapy. That is actually something that I think we need to ask when we approach our patients. So I think this is a major progress, but the reality is that it may be restricted to centers or countries where we have this kind of molecular data that may not be all over the world for sure. So the question is, moving forward, how we're going to do this? We have a molecular classification for some type of people and a non-molecular one for some others. I don't know how we're going to be really implementing this. But this is very quick introduction in terms of what's happening with classifications, WHO, ICC, IPSSM. Let's start with the low-risk myelodysplastic portion of this seminar. And we'd like to have some clinical vignette to maybe help us. And I don't remember if I read this and I ask you. Okay, thank you. So Ellen, okay, is a 75-year-old woman that is referred to a clinic for primary care. And in that evaluation, the patient has anemia, as you see there, with a hemoglobin of 7.5. Platelets are okay, 200. An ANC that is also good. No nutritional deficiencies, no bleeding. And there is evidence of ring sideroblast, in this case around 20%, with erythroid dysplasia. Of course, you perform this bone marrow exam where you visualize this, and you see 2% blast. And because you're here in Houston or in Baltimore, you have access to a powerful NGS assay, and you find that this patient has a mutation on this gene called SF3B1, on this particular codon, at a VIF of around 28% on this NGS panel. And then on your right, you see the morphological characteristics of this film and the evidence of ring sideroblast. So, Amy, do you want to walk us through this?
So, the one thing that I think is interesting about this patient is by the time she got to be 75, I have to assume that she had been anemic long before she presented with a hemoglobin of 7.5. And we were speaking in a session earlier this morning about how in the United States, sometimes patients are coming to presentation a bit later by the time they're already transfusion dependent or closer to transfusion dependence. And I think this is an example of this. The other thing that clinically I would find useful to know here is perhaps her MCV, just as we think through this. But it really is appropriate in a male or a female in this age range who is truly cytopenic. And yes, the platelets are normal, and yes, the absolute neutrophil count is normal, but this is real anemia, to do a marrow assessment. And I think the earlier that diagnostic procedure can be performed is really the question that the first thing alludes to is that's how you get your bone marrow biopsy if you get referred to a hematologist oncologist. And certainly the wait times are long, and these are challenges in our current healthcare arena, but I think it's really important. And I do enjoy it biologically when the morphology mirrors, so the phenotype and the genotype, and this patient really does fit. She has ring sideroblast, she has erythroid dysplasia. And this is actually not the most common SF3B1 mutation. K700E is more common, but all of these mutations we believe yield a better prognosis for these patients. We'll talk about how it may help us guide some therapeutic decisions, but this all fits for the patient, and she meets those minimal diagnostic criteria that Dr. Garcia-Manero alluded to that make her MDS diagnosis. And I would calculate an IPSSM because I'm in an academic center for this patient, but I think we can mostly tell by looking that she probably has a lower risk phenotype with one cell line down. and no other co-mutations with her splicing mutation, which is important to think about for her. And I would calculate the IPSS-R and the IPSS-M for her. And maybe some of you have these sophisticated patients that come in carrying their report that already has the information on it. And we would talk about how sometimes the addition of the molecular information can upstage you, but in this case, I think she would be low risk in both.
So what we see is that the confirmation of the diagnosis by IPSSM, and then in addition now you see that this patient has a transfusion burden of 3 units over a 2-month period. Does this change your perspective in terms of the patient?
To me, that's true transfusion dependence. I think we all are aware of the low transfusion burden and the high transfusion burden, 2 units, 4 units, how we characterize it. But it is not normal in 8 weeks to get 3 units of somebody else's blood. So yes, I believe she is transfusion dependent.
And then the next question, now that this disease is just changed in a way by the fact that it's needing this transfusion, does the new data from the COMMANDS trial with luspatercept change your practical approach to this patient, as opposed to maybe, let's say, 6 months ago?
So we have had some exciting times in the lower risk MDS space, and now we have an approval that this patient would truly fit the label for, and I think that's important in guiding our thoughts, and you'll share with us some of the data. I think the discussion I would have is she still has probably 3 therapeutic options. One is ongoing transfusion use, which is not what any of us yield for because blood is a limited resource. I think an ESA remains a discussion point, but if we follow the COMMANDS data, luspatercept is a very reasonable option to raise her hemoglobin here. And I do tend to follow the label in terms of practical dosing recommendations. We don't yet know that she needs a higher dose, so we should start at 1 milligram per kilogram. And I'm a practical person, and some of my patients are very cost conscious, and they often ask me cost questions about what's their copay going to be and things like that, and I think we would explore that all in the context of taking global good care of them.
Okay, so the take-home messages right now from this first presentation are shown here. That is, as Dr. DeZern said, that historically these patients with anemia have been treated with supportive care and an ESA. And we're going to be reviewing in a second, and then later on in the afternoon, evidence coming from this randomized study called the COMMANDS trial, where up front we compared luspatercept versus an ESA in this group of patients. And perhaps the consideration that now we should consider this agent as the standard of care for this group of patients. Now, if we go into how we assess patients with MDS, this is kind of an algorithm that is a simplified kind of NCCN guideline. What we do is we divide patients by this consideration of lower versus higher risk disease. You can use IPSS-R, more or less than 3.5 points. You can use IPSS-M, that's a little bit easier. I guess you can still use the all IPSS. You see the different subsets there. And then I think when we look at the lower risk disease, you see some of the approaches that we have had for many years. They go from iron chelation, growth factors, luspatercept that was already approved as second line for ESA failure in the context of ring sideroblastic anemia. Something that is very North American, that is the use of hypomethylating agents, particularly lower doses of the azacitidine, maybe now the oral hypomethylating agents. And for sure, the most effective therapy in the correct context, that is lenalidomide for those patients with del(5q) disease. There are some patients with what we call hypoplastic myelodysplastic syndrome. Indeed, again, Dr. DeZern is an expert on this particular condition that we tend to treat like a plastic anemia, or at least I do, and okay, of clinical trials. And then we'll be discussing in the second part of this symposium high-risk disease, where I think age of the patient, whether the patient could be a candidate for induction therapy or hypomethylating agent or a transplant, is something that is very important, and we'll have time to go through that later. So for, I guess, 20, 30 years, actually, I have no idea, for as long as I've been practicing as a hematologist, as a actually intern, ESAs were the center of our therapeutic approach for this group of patients. So this is part of our kind of everyday practice. It's interesting, though, that they were not really, at least in the United States, formally approved in the context of true modern randomized studies like what we have to do right now for instance, luspatercept or imetelstat that we'll also be discussing later. And there are issues with these transfusions, right? Of course, for the patient, iron overload, maybe risk of infections. But the reality is that we learned a lot through the COVID times, and still we are going through that in terms of the impact of these transfusions, the ability of getting these donors, transfusion our patients effectively, and actually the significant cost to institutions like MD Anderson that they had to build quite a bit of an infrastructure actually to support their blood banks that may be perhaps unique to my institution. So there was a major need for a second line or a new agent to improve erythropoiesis in patients with myelodysplastic syndrome, potentially other conditions. An example of this is luspatercept. So the question is, what is this agent? Actually, it's quite interesting because what this drug does is basically a fusion protein, so an antibody, that basically will bind to ligands to activate a pathway that we would like to shut down in patients with myelodysplastic syndrome. Basically, by inhibiting the inhibitor, we promote erythropoiesis. And it does it in a different way than an ESA that works maybe more at the earliest stem cell level. This actually works more as a maturation type of agent, modulating this TGF-beta pathway in patients with myelodysplastic syndrome. Now, to be clear, this is not just super specific for MDS. The good news is that this has other potential roles in other diseases like in thalassemia, where there's also an indication. And I see actually that there may be other conditions where this kind of agents modulating this pathway could have an important role, resulting in improvement in erythropoiesis in our patients. So we had performed a prior study known as the Medalist trial. This led to the approval of this drug in second-line rheumatoid anemia patients. And one take-home message from that study is that this drug is actually quite safe, as you will expect from a drug with these characteristics. And we also saw a phenomenon by which patients with what we term a lower transfusion burden actually had potentially a higher rate of response. So our view was that it made sense actually to position a compound like this in the front line, right? So if it's working in second line, you have an acceptable toxicity profile. Why not testing it in the first frontline context? And that's what we did. Now here, we felt, we were part of the steering committee of this trial, that would be, of course, unethical to compare it with placebo or without intervention. So we did the logical thing that was to compare it or randomize it against an ESA. And that actually is the genesis of this COMMANDS trial. It was published in The Lancet with Dr. Platzbecker a few months ago. It was presented at ASCO and EHA, and led a couple, I think last week, right? To the approval of luspatercept for patients with anemia with low-risk myelodysplastic syndrome. So here you see kind of the schema of this study. So patients with this disease tend to be older than 18. We use IPSS-R as the kind of classification because that's what we had basically when we designed this trial. We had very strict definition in terms of transfusion dependency that you see there. And this question comes all the time. Why did you restrict the EPO level on the study to 500? That's actually very important because we were comparing with an ESA, right? So it will be not fair to use this in patients that have very high EPO levels where it will be very unlikely that an ESA will work. So that question comes, and I think is important to really address it. And of course, this is a frontline study, so this is for ESA naive patients. This was a one-to-one randomization between luspatercept and epoetin alpha, a commonly used ESA. And I think what is really important is what the endpoint of the study that I think maybe was on the prior slide, but basically wanted to have two things. One was the rate of transfusion dependency for 12 weeks, but also a concomitant increase in hemoglobin of at least 1.5 grams. So this is very important because you're looking at a threshold of hemoglobin plus duration of transfusion dependency. And the data from this intent to treat analysis that you see here, and this is the primary endpoint of the study, is very clear. So those patients treated with luspatercept, regardless of the type of MDS that they had a response rate was close to 60% versus 30% for those on the ESA. So basically doubling this response rate of duration of transfusion dependency plus increments in hemoglobin levels. So on this slide, that I think is very important, on the left, you see the intent to treat, basically all the patients. This is the way the study was designed. Now, on the right, I hope left and right is good here because that's what I see here, so I hope it translates into what you guys are watching. But bottom line, what you see here is the rate of response for a specific subset of patients. So those that have a higher or lower EPO level, those that had more or less transfusion needs, or what we call transfusion burden, let's say 4. I think the question that comes now that is very important is that of the phenotype of the disease. What you see in the slide is those patients that are positive for ring sideroblasts, so ring sideroblastic anemia, they have a very clear major difference in terms of response compared to those that did not have that phenotype, whereas that actually is not that clear in those patients that are RS negative. Indeed, actually, the RS response was a little bit lower for those patients treated with luspatercept in the context of RS negative disease. Now, when we look at mutated disease, meaning SF3B1 is in the direction of what we see in ring sideroblastic anemia, and actually in those patients that are wild type, meaning they did not have the SF3B1 mutation, the response also was in favor of the luspatercept. I personally take this trial as an intent to treat study because it was actually not really stratified or controlled for whether the patient will have ring sideroblastic anemia or not, but someone may not agree with me, and there could be a discussion about this. The reality, what I think is very important from the trial is actually not the response rate, that is nice. What I think is important actually is the duration of that response. And actually, if you look at this data, what you see here is that the duration of response was 122 weeks in this analysis versus 77 weeks for those patients on the ESA control. If you think about this, this is 1 year of transfusion-free survival. If you think about this, you understand the magnitude of this type of strategy for this group of patients with lower risk myelodysplastic syndrome. So indeed, to me, actually, that is more important, although it may not be the primary endpoint of the study per se. But when I look at the quality of this data, I think that's actually very positive. Now, going back to this topic of RS positive versus RS negative, so what you see on the left is the duration of responses with luspatercept versus ESA in the RS positive context. That's very clear, so 120 weeks versus 47 weeks. Probably it's better to talk about hazard ratio, so it's around 0.6, so it's a 40% improvement. But what about the RS negative, where the responses seem to be equivalent? What you see there is that the median duration of response had not been achieved for those patients treated with luspatercept versus 95 weeks in those patients treated with epoetin alpha in favor of the luspatercept, although the number of patients with RS negative disease was actually significantly smaller on this trial for reasons that are not clear to us on this COMMANDS trial. In terms of safety, the safety profile of both compounds was quite similar. And I think basically this data, in my opinion, establishes this compound as a very effective frontline agent for patients with anemia and low risk MDS. But there's some nuisance, right, that Dr. DeZern was asking or kind of describing at the beginning of this conversation in terms of the cost of this drug. What will be the role in patients with RS negative disease, et cetera. I think that we're going to be learning as we get more and more experience with this compound. But I think this is the first prospective randomized study in this particular context with hazard ratios that are very clearly in favor of the luspatercept in this intent to treat analysis. So with that, we'll go to the next question and see how you feel about all this. That is, how will you manage a 75-year-old patient with low-risk MDS, with ring sideroblast and anemia that comes to your clinic with 3 units of red cells required over an 8-week period? You are not sure? Please don't answer that. It will make us look very bad, right? Continue red cell transfusions, use lenalidomide, use ESA therapy, or use luspatercept. So if you can vote, please. Thank you. So majority of you are familiar with the data, and I think they agree with the results of the study. So I think I will also support that particularly approach. There was a 3% not sure, okay. For sure, you will continue supportive care with the transfusions. We're not saying we stop that. And there will be no role, to my knowledge, for lenalidomide in a non-del(5q) minus MDS patient. So that's great. Okay, so the next question is, can you now pinpoint the main efficacy outcomes from the COMMAND study testing luspatercept versus ESA in therapy in first-line management of patients with low-risk MDS with anemia? So again, I'm not sure. Luspatercept improved the hemoglobin levels but did not affect transfusion dependency. Luspatercept improved transfusion dependency initially, but the responses were not durable. Luspatercept improved transfusion dependency, but with a concurrent mean hemoglobin increase. There were no difference in terms of TI between treatment arms. Please, if you can vote. Perfect. So that was the main result of this, that luspatercept resulted in an improvement in transfusion dependency rates together with an increase in hemoglobin. So very nice. Okay. And now I'm very happy to give the podium to Dr. DeZern. Thank you, Amy.
So we'll go back to Ellen, who's our same patient that we started with. And remember, we diagnosed her with lower risk MDS, and she had her anemia. And her first-line therapy did include an ESA and red cell transfusion. She probably got treated before August 28th, so that's probably what happened. But after about 15 months of therapy, her transfusion requirement increased to 3 units a month, and she had a very elevated serum EPO level. So, Dr. Garcia-Manero, do you consider this an ESA failure?
I don't think, can you hear me?
Not really.
So, of course, this is what, it doesn't really matter whether I think it's failure or not. This is actually what the patient is going to ask you in the clinic, right? This is really bothersome to an individual, having to go to clinic, getting this transfusion. So this patient obviously is not responding anymore to the ESA, probably is having problems with the transfusions, etc. So you need to look for a second alternative. And the question is, what are the signs of this ESA failure? Actually, this is very easy to measure, right? Like the amount of units that you are providing to that patient in a particular chronological time. And the question is, what are the options that we have for our patients right now? And I think you're going to be discussing this in the next few minutes.
And I think, just to highlight something Guillermo said, is often failure is as much defined by the patient as it is for us. And our ability to tell them that they have therapeutic options is really important. And towards that line, we're going to talk about one thing in particular, and that's imetelstat. So before we go into the granular data, would you say that the iMERGE study suggests that imetelstat can be used as a second-line option?
Yes, I think that the data that has been presented both at ASCO and IHA indicate in randomized study you're going to be discussing now that this drug is active in this group of patients. Absolutely.
Right, and I think there's, again, the discussion of options includes clinical trials, which is the data we'll discuss here from the iMERGE study on imetelstat. You've heard a few other options that we've, in the question prompts, lenalidomide, ongoing transfusion support. In his flow chart, Dr. Garcia-Manero mentioned that even hypomethylating agents may be a point of discussion. But let's really talk about some newer drugs that we can think about in terms of new mechanisms of action and how much we need this for our ESA refractory patients. And really, I always describe it to the patient as the goal is to eliminate transfusion burden because that diminishes their healthcare quality of life. And also, blood is not an unlimited resource and comes with transfusional iron overload, among other things. We've talked about how the MEDALIST trial, which was approved in brought luspatercept to its initial approval in 2020 for somebody who has ring sideroblasts and was an ESA failure. lenalidomide, and then we're going to talk about the newest option that may be on the table in the relative near term of imetelstat. And I mentioned that lower dose HMAs are also an option. It is sometimes academically of interest to characterize how we define a patient who is truly erythropoiesis-stimulating agent resistant or refractory. I'll be frank, the patients don't get muddled down in primary versus secondary refractoriness or resistance, and frankly, they just don't care. They want to get less red cells, and sometimes I fall into that hole myself a little bit. But primary resistance is actually not uncommon. And then relapse is particularly common because, as we know, MDS, especially low-risk disease, is a chronic, non-curable disease with all the therapies we're talking about today. And so ultimately, over time, patients are not going to maintain their initial response. One clinical pearl that I'm sure you all know is we do need to make sure, as we're stimulating the patient's erythropoiesis, that we're keeping them iron replete. But in the absence of supplementing them with iron, the median duration of response is usually 18 to 24 months, and I think that certainly bears out in our clinics day in and day out. Some of these scoring systems are from publications from the Nordic group a number of years ago, and it can be useful when we're thinking forward with our patients to balance how likely we think they are to respond. Baseline EPO level is very important. How transfusion dependent they are when we meet them is useful. But really, up until August 28th, we try these and we use them as long as we're working, and we have to think about second-line therapies. When the Medalist trial brought luspatercept to its initial approval, it was very much a needed drug and the first approval in our MDS space in a long time. But what publications have come since, this most recent one from the group in Blood just last year, showed that longer-term evidence confirms that there continues to be that substantial reduction in transfusion burden with ongoing luspatercept dosing. And I do think for managing expectations for perhaps older patients who are going to have this disease for many years, this type of data is really useful to know that they can be on it for a long time and continue to maintain that transfusion decrease and hopefully independence for as long as possible. And I'll just mention one last thing about, we're not showing here swimmer's plots, but 1 unit transfusion that may be a blip in somebody's course of ongoing luspatercept dosing at every 3 weeks is something that we should be mindful of and make note of, but perhaps they had a little bit of a GI ooze or something like that. We do want to make sure that, given we have a paucity of drugs in our field, we're using the ones that we do have as long as possible. So let's talk about imetelstat. Imetelstat is a drug that you've heard of. I think the trial has a pretty cool name, the IMerge trial, and the early data showed that it selectively targets malignant cells through a mechanism with telomerase and induces apoptosis. It's really a different mechanism than we've used in MDS, and that in and of itself is enticing as we look for new agents for our patients. And it has very potent activity, particularly in our anemia-predominant MDS patients with ring sideroblasts. So after some very compelling phase 1/2b data, the IMerge phase 3 trial came with a very similar approach. It's randomized at IV dosing to placebo. So this is truly a registration trial that's double-blinded and randomized. Because it was developed a few years ago, it actually uses the IPSS, not the R and not the IPSSM that we spoke about this morning, but it's still applicable. And so the patients, to be eligible, needed to be relapsed or refractory, and we've talked a little bit about what that means, or have a baseline erythropoietin level that was elevated, so really someone not eligible to receive an erythropoiesis-stimulating agent. And they also had to be pretty transfusion dependent with 4 units or greater in an 8-week period over the 16 weeks prior to study enrollment. So this was pretty rigorous criteria, but I think we all know these patients are out there when their anemia from their bone marrow failure with their MDS is getting worse. And these patients could not have 5Q, and they could not have previous treatment with lenalidomide or hypomethylating agents. And as I mentioned, it is a randomized study. What they were really trying to understand is 8-week transfusion independence of red cells. And what they've shown, both at ASCO most recently and in some other smaller abstracts, is there's a higher rate of longer-term duration of transfusion independence when you get imetelstat compared to someone who's only receiving a placebo. This is meaningful difference in these bar graphs. As you can see, the p-values there. It was a 2-to-1 randomization, and when the patients received the imetelstat, they were able to maintain 8-week transfusion independence, which is the first thing that you're seeing here, and then also 16-week transfusion independence, and also 24-week independence, and even some at 1 year. Obviously, there's a little bit of a degradation, but the fact that there's still that percentage of patients at 1 year maintaining transfusion independence really suggests to me quite an active drug in the space. And remember, this is less time in the clinic, not sitting in a chair, receiving 1 unit of red cells over 2 hours every week. This is really clinically meaningful for patients. And when somebody responded with that transfusion independence, that continues, as you can see here, in a longitudinal fashion with a little different display of the data than we just showed. The duration of that response, you can see for the 8-week responders, was quite different between the imetelstat active patients compared to the placebo. And when we see separation of curves like this, we really know that the drug, we hope, is changing the natural history of the disease, but certainly changing the life of the patient, which is invaluable for MDS. We're always worried in a chronic condition, predominantly of older patients, what the side effects are. Because yes, it's nice to be transfusion independent, but not if you can't get out of bed. But really, these adverse events were mostly hematologic. They were consistent with what we've seen with other interventions. In grade 3-4 thrombocytopenia and neutropenia, so this is a myelosuppressive drug, were the most frequently reported, but there were no fatal hematologic adverse events, and the non-hematologic adverse events were quite low. A lot of dose modifications were necessary, and I think we're all learning in heme malignancies across the board how important it is to titrate these drugs to what is going on for our patients. And we're also mindful, particularly of liver toxicity in these possibly iron overloaded patients who may be getting other hepatotoxic agents. But overall, I think given the potential for transfusion independence, this toxicity profile may be manageable for our patients. So let's go back and think about novel mechanisms of action for this particular drug. Okay, please go ahead and vote on your phone. We're just running a little bit out of time. Soho has told us, but we'll continue forward and I'll hand it back to you, right?
Okay, we need to be on time from Soho, so we move. So I think what you heard is that now in low-risk MDS we have two new therapeutic, hopefully very soon, two new therapeutic possibilities. And now we're going to move into lower risk syndrome. And this to me is very ironic because, I thought we were not going to make any progress in low-risk disease, and now, here we are making quite a bit of progress. And if we had time, we could go through a list of agents that are being studied in low-risk disease that I think are going to be also very important, which is kind of paradoxically. So let's see where we stand now with high-risk disease. So we have this patient, Alex, 70-year-old man with confirmed myelodysplastic syndrome, has anemia, has some symptoms, bone marrow shows 9% blast. This patient has a TP53 mutation with a complex karyotype, is getting weaker. You are not clear in terms of donor search. And if you remember from the IPSSM, we didn't really discuss this, but if you have used the IPSSM, you will see that there will be a clear question there at the very beginning, that is, does your patient have a P53 mutation? Is this mono versus biallelic? Here they call it multi-hit. So you will see what the important prognostic value of those mutations are in this patient. So this is actually a common patient that we see at MD Anderson, probably the same at Johns Hopkins, and remains a major problem for our patients. So the questions, and I'm going to ask them to Dr. DeZern, and are actually quite difficult. So the first one is this 70-year-old man with P53 mutated high-risk disease a candidate for transplant or not? Number one. I think that should be perhaps kind of your short-term goal. The second is this patient a candidate for induction chemotherapy versus a hypomethylating agent? And is there a clinical trial that could help your patient? So, Amy, how do you see this?
So these certainly are loaded questions, and I will make a disclosure that I am a card-carrying transplanter. However, what guides my decisions in that potential path to cure for patients, and I always say it like that in clinic, is quality and quantity of life. Some people will say you should never transplant TP53 disease, and I do not agree with that statement. However, in this particular setting, he is 70, so we have to assume in the United States his life expectancy, if he did not have this, is another decade, give or take. But he has very poor risk features, and 2 TP53 mutations, so multi-hit with a complex karyotype, is usually not a patient that the immunologic effects of transplant can cure. And so that is less on the table. It's whether or not we can extend life with quality. And so I think that moves us to the second bullet point about how we choose to maintain control over the disease in contrast to pursuit of transplant. And I really spend a lot of time managing that expectation for patients. I'm also not sure that patients like this benefit from high-dose chemotherapy, but I think there certainly is a role for clinical trials and HMA therapy to quiet the disease down and go for some extension of life.
I agree with you, Amy. So I think right now there are actually very few good options for such a patient. I see some of the people that work with me in the clinic, I go like a step-by-step type of situation. I don't know that I will make a categorical decision today whether this patient is a candidate or not. You like to see, does the patient respond to therapy? What is the depth of this response? What type of donor, etc. And then at some point, you probably are in a better position to make that kind of important decision more than on the very first day. Although for some of these patients, this is actually quite obvious. I think still the hypomethylating agents as single agents actually remain the standard of care for our patients. I don't think that I will be treating a patient with these characteristics with induction therapy. And the question is, will there be some form of immune therapeutics, let's say a TIM3 inhibitor, perhaps potentially effective in this context? So this slide has a typo because maybe should said high risk, so I apologize about this. But we went through this at the beginning. Here the question is this a younger patient? For me, pediatrics is like 60s, so that's good. Or is this an older patient? Now, this is very important. This morning I got a question about 43-year-old man with MDS, similar characteristics. I'm not sure that I will apply the same type of information that I'm going to give in the next couple of minutes, but I think those are unique patients, not that really common. So I think 70 will be the proper age, and then your decision will be induction therapy, hypomethylating agent. I think in this context, a hypomethylating agent will be the standard of care, and then the question is this patient a candidate for transplant? And more important, perhaps also the timing of that transplant. Should you take this patient to the best potential cytogenetic molecular response if you're able to achieve that, or do you just do that at any time whenever you can? The other important thing is that data with these hypomethylating agents keep changing. You know, we thought they were very inactive, and now we're starting to get randomized trials where the single agent is outperforming any doublet, which is incredible. And we saw data actually at the last ASH meeting with oral decitabine cedazuridine, with actually very intriguing activity both in mono and biallelic P53 mutated disease. I'm not saying that this is a P53 directed agent, but there is clear evidence that this new class of oral agents can be quite active in this group of patients with P53 mutated disease. Now, a few days ago, I was on vacation, so everything is like a few days ago. I don't know if this is a couple of weeks ago, but recently we heard about actually the results of a trial that we were very excited. Unfortunately, turned to be, although we have not seen the data per se, a negative study, that the so-called enhanced trial, where we combine azacitidine with or without a CD47 antibody known as magrolimab, that we felt was kind of agnostic in terms of the P53 mutation. I think, although this is a negative study by the report, we really need to see the data and learn from this kind of very large study that we conducted, our patients conducted, and was supported by Gilead. So we really need to learn from this. Now, this opened the door to other forms of immune therapy. An example will be targeting this molecule known as TIM3. This is kind of another checkpoint There's also data that this resides in the leukemia stem cell per se, so it may have a dual role in terms of its activity as an anti-leukemia agent in combination with hypomethylating agent. And this actually has led to a number of clinical trials that we call stimulus. There are a number of them in MDS, in AML, and we saw data at this past ASH meeting by Dr. Zidane from one of the first reports from randomized data. So the TIM3 inhibitor that I'm talking about here is called sabatolimab, and again, this was in patients with myelodysplastic syndrome, combining it with decitabine or your hypomethylating of choice that could be either azacitidine or one of the oral hypomethylating agents. One of the key questions with these forms of immune therapy is the toxicity profile that could be quite severe with like canonical PD-1, CTLA-4 inhibitors. Actually, this TIM3 inhibitor was quite well tolerated. But the question is, are we going to have enough data to support the approval of such compound? These are like early days. There is a thought that perhaps a drug like this could maintain responses. So therefore, a longer duration of the evaluation of this trial could be quite important, similar actually to what happened in the early days with ipilimumab in melanoma, where a not very active approach actually resulted in significant improvement in survival. So I think it's quite important that we see that. And then interestingly was that this kind of approach actually seemed to be also what I refer to as agnostic, meaning not directed against the p53, but actually having activity in this group of patients with very poor risks. So this is the phase 3 stimulus MDS2 design. Again, this hopefully will give us a final answer in terms of this question. Of course, other doublets are those with BCL2 inhibitors. We don't really have time, and probably you are very familiar with the mechanism of action. These drugs are already approved in combination with azacitidine for patients with acute myelogenous leukemia, and they indeed actually constitute the standard of care for a large fraction of patients with elderly AML, and it's therefore logical that we study this as well in patients with high-risk myelodysplastic syndrome. There are a number of studies already exploring, actually reported, the combination of HMA plus venetoclax, and what we see from those studies is a very high rate of response that could be actually over 90%, depending on what type of criteria you see. But more importantly, we see that the expected survival from this phase 1 kind of early 2 studies actually longer than expected to what we consider to be this, what you will see with single agent hypomethylating agent. Now, there is a caveat that this drug actually may not be that active in the context of p53 mutated disease, so we probably need to learn how to use this. And then another, in this particular molecular context, and then another issue that is quite important is that this kind of doublets with venetoclax and an HMA has resulted in a very high fraction of patients going to a stem cell transplant. Now, this may not apply to the patient that we are discussing, but in other contexts, let's say non-p53 mutated disease, this actually could be a very important issue. And what we're seeing at MD Anderson actually is that we are having the highest rate of transplant patients that we ever had, thanks to this kind of doublets in clinical trials. Again, this is nice data, but we need to see the results of this trial. This is the phase 3 randomized study of azacitidine with or without venetoclax. It's called Verona. We don't know when this study is going to read. I understand maybe at the end of this year, maybe at some point early next year. I don't really know. But we are really, in a way, anxious about the results of this trial because, we're seeing this kind of hard, depressive state where these big, very well-designed randomized studies fail with pembrolizumab, now with magrolimab, and hopefully this will be the study that will take us to an improvement in therapeutics and survival for our patients with high-risk disease. The good news is that there are actually other drugs coming, and this is actually led by Dr. DeZern, where, for instance, there may be approaches for molecular therapeutic targeting in patients with MDS. So it turns out that a subset of these patients with MDS and also with CMML, they may express a gene expression signature similar to what you see in acute promyelocytic leukemia. So basically, they are RAR alpha, and therefore it will make sense potentially to use an inhibitor of this potential pathway in patients with MDS and maybe AML, and that's actually the basis for this SELECT MDS1 study that is going to be targeting this subgroup of patients that have this specific gene signature. Of course, these are early days, and hopefully we'll see very positive data, because at the end of the day, maybe in MDS, we need to break these diseases in different subgroups and really attack individually what will be the major molecular problem. We don't have time, I'm told, for the questions, but please do the QR, because we will follow up on those questions. And it's actually very sad. Soho is making us cut the meeting a little bit short, but there's a bunch of very important questions on the tablet. So I don't think, Amy, we're going to have time to really go through them. I really apologize, but Dr. DeZern and myself will be happy to talk to you. And with that, I really want to thank you for this opportunity, for listening to us. I think we're living through very exciting times in patients with myelodysplastic syndrome. We put a lot of energy, all the room here, for almost 20 years in trying to improve outcomes, develop new drugs, and I think we're slowly getting there, so I'm very grateful to this community. And thank you very much, Dr. DeZern, for bringing such a great partner. Thank you.
There's some good questions, too.